Alright, with your potassium-sparing diuretics, again, indicated for edema. Typically with these, it's going to be combined with another diuretic, like your thiazides and or your loop diuretics. If you have all three of them working together, it's something called triple therapy, where it's like all the diuretics, pretty much. Amiloride, and others can help inhibit your hypokalemia that you see with your thiazides and your loops. And it just inhibits that potassium from getting secreted into the distal convoluted tubule. Different drugs in this group, like they all spare potassium, but some of them do it differently. Like your spironolactone, this one is going to be antagonistic to aldosterone. Remember, aldosterone is a mineral corticoid, and it helps to get rid of potassium and maintain sodium. So you're keeping sodium in water and losing potassium. This is antagonistic to it, and so it stops it from working on that distal convoluted tubule, while the other two just stop sodium from being reabsorbed in that location. So the way it gets reabsorbed is with the exchange of that potassium. So if you're not allowing that sodium coming in, you're not going to also allow that potassium to go out. Side effects: nausea, diarrhea, hyperkalemia. So this one is too much potassium. And then we get to our vaptins. These are all ADH antagonists. ADH is anti-diuretic hormone. It is a hormone that stops you from urinating, right? It helps to help. Sometimes it's called vasopressin because it raises your blood pressure. Convaptin is a pretty good example of a vaptin. The mechanism of action is it binds to your V1As and your V2s ADH receptors. They cause aquaresis, where you have water loss without electrolytes. And so you don't have to worry about the changing of the ions like we have with some of our other ones, right? With your carbonic anhydrase inhibitors, your thiazides, your loop diuretics, all those are causing ion changes. Your potassium sparings are even causing some ion changes. Your vaptins and your osmotic diuretics don't do that. Things you see: dry mouth, thirst, headache, hypotension, vomiting, constipation. Contraindicated with anything that blocks the P450 enzyme system. It's a pretty important enzyme in metabolizing drugs. And so stuff like clarithromycin, ketoconazole, because they all work in that same system, you can get too much of these drugs circulating in your body. And then the last group of our diuretics are your xanthine diuretics. This is a lot of your over-the-counter diuretics are going to be xanthine diuretics. They're going to have caffeine in them. These are naturally occurring drugs. Pretty mild diuretic response. If you drink coffee in the morning, or if you drink tea and you're like, man, I always have to pee after I drink coffee or tea. Well, that's because it is a diuretic. What it does is it increases the blood flow through the kidneys. That increases that glomerular filtration rate, which then increases urine formation. The way it works is by stimulating the central nervous system a lot of times, and so speeding up your heart rate, dilating your blood vessels, that kind of stuff. Again, hypotension, headache, and I love this little meme where it's like, I'm not sure if my headache is from too much coffee or not enough coffee. Depends on how addicted you are to coffee, right? Okay, then we're going to get into our hypertensive drugs with a little background about what is hypertension, what causes it, why do you not want to have high blood pressure. Well, it can cause cerebral strokes, it can cause heart failure, it can cause left ventricle hypertrophy. Here you can see that there is like no room. All the muscle has built up here in this left ventricle. This is the right ventricle, right here. Left ventricle, there's no room for blood to even fill up before it contracts, because that systemic blood pressure so high, the heart has to work so hard it just keeps building up that muscle. There are two types of hypertension, or two ways we can categorize it. One is with essential hypertension, which means we don't know what the source is, but you do have high blood pressure. And then secondary hypertension is we do know what the source is, and so you can treat whatever that source is to treat the high blood pressure. With essential, it is we're just going to give you drugs that bring down your blood pressure. So blood pressure is just going to be the interaction between your cardiac output and your peripheral resistance. Cardiac output is beats per minute times stroke volume. So how much blood do you pump per minute is your cardiac output, and then whatever that peripheral resistance is going to give you your blood pressure. So the higher the resistance, the higher the BP. What are things that can cause resistance? Clogged arteries is a great example of something that can cause increased resistance. So your kidney is going to be important in this group. Typically when you think about blood pressure, you're like, oh, of course, the heart, that's important, right? But also your kidneys, because you have that renin, angiotensin, aldosterone system that we mentioned when we were talking about diuretics, where the kidney picks up on blood pressure. If it's low, it's going to cause an increase in renin, which is going to cause an increase in angiotensin, which is a vasoconstrictor, so that's going to raise your BP. And it's also going to work on aldosterone, so you're going to be retaining more sodium, more water, which again can raise your BP. There are classifications of your hypertension. So anywhere between a systolic 120, diastolic 180 and below is normal. Getting above 120 and up to 90 on your diastolic will give you pre-hypertension. And then 140 through 90 is you're in hypertensive, and then stage 1 and stage 2. So, like we mentioned last time, thiazide diuretics are a good way to bring down your blood pressure because you are decreasing the overall water that is available in the plasma. So you're decreasing the amount of plasma, you're decreasing the amount of blood, you're decreasing the amount of blood pressure, right? Side effects, again, hypokalemia, not enough potassium, dehydration, muscle weakness, fatigue. Those kind of go with dehydration. Then we have our sympatholytics, your alphas and beta blockers. So you have central acting drugs that work on the sympathetic autonomic nervous system, and then you have your alpha 1s and your beta blockers. So in your central acting drugs, clonidine is kind of the preferred one to go with. It works on the medulla oblongata in the brain to decrease your vasomotor centers. And what they do is they stimulate the inhibitory alpha-2 receptors. So what that says, if you remember what your alpha-2s do, is when norepinephrine binds them, they stop releasing norepinephrine, right? And so when clonidine binds these alpha-2 receptors, it tells the body to stop releasing norepinephrine, which decreases sympathetic stimulation in both the heart, kidneys, and the blood pressure, and the blood vessels. All those can decrease your blood pressure. So you're decreasing the cardiac output, you're decreasing that renin, angiotensin, aldosterone system, and dilating blood vessels. For your alpha-1 blockers, if you remember, alpha-1 adrenergic receptors cause vasoconstriction, and so for blocking that, it's going to cause vasodilation, which decreases that peripheral resistance, which then decreases your blood pressure. Tyrosine is kind of the go-to for this one. With your alpha-1 blockers, you can see that burst dose phenomenon, where you take it and you get lightheaded, dizziness, orthostatic hypotension, possibly fainting, but then your body kind of readjusts to it. You might also get dizziness, blurred vision, or tired with your alpha blockers. Beta blockers, we've talked about beta blockers before. You know, metoprolol is probably the go-to for decreasing blood pressure. And, you know, they just decrease the cardiac output by decreasing how fast the heart beats, lowers the blood pressure. And a lot of these, they also suppress renin release. And so you don't have to worry about the activation of that renin, aldosterone, angiotensin group. All right, vasodilators work directly on the blood vessels, causing dilation, right? Here you also get triple therapy when you're working with your vasodilators, because they're often used with diuretics and beta blockers. And so you have 3 levels of trying to decrease your blood pressure. If you just use vasodilators alone, you're going to cause fluid retention, so you're going to start getting edema. That's why you need the diuretics. You also will get reflex tachycardia, which is why you need the beta blockers. Hydralazine is going to be a really good arterial dilator. So it dilates the arteries, which is going to decrease that systolic blood pressure for you. Causes nausea, headache, hypotension. Long-term use may produce rheumatoid arthritis or systemic lupus erythematosus-like syndrome. And so it gives you lupus-like symptoms. Minoxidil is better than hydralazine, but can also cause myocardial ischemia, pericardial effusions, and then growing of hair. Which is funny because minoxidil is actually, the topical preparation of that is Rogaine. So they're like, hey, this stuff can cause unwanted hair growth. They're like, but what if it's wanted hair growth? Well, let's make a new drug. And so Rogaine is basically a vasodilator for your head. Then we have our calcium channel blockers. Again, we've talked about these before. Nicarbamide is not going to give any cardiac changes. It is just going to dilate those blood vessels, while verapamil will also give you cardiac changes, working on that SA and AV nodes. All right. The next group, we're talking about reducing angiotensin II.